Great. Thanks so much for joining me today. Why don't we start with the classic, who you are and what do you do?
Hi, Harold. It's so good to see you. I'm Amitabh Chandra, and
Mhm.
I'm a professor at Harvard Business School and at the Harvard Kennedy School of Government, and I'm an economist.
And you do a lot of health economics.
I do. I kind of stumbled into it, right? I wasn't trained as a health. I'm an imposter, Harold. I kind of fell into it, as you know.
Oh, how did you get the invitation to this thing?
Yeah, I don't know. You invited me to do it. I happen to do some health economics, but
yeah.
I'm not credentialed in it.
Oh, there you go. Well, as an imposter, you may actually have a better cover story than many of the people who are legit, so we can go about the interview. There, um, so by the way, one of the things I should say that one of the articles that you wrote that I'm really struck by, which gets to many of the themes that our students, I'm hoping, will learn, is this: what does a deductible do? And thinking about how, we obviously have this problem that we're trying to encourage people to use more high value healthcare and less low value healthcare. And maybe we can just start in a very practical way. What are insurance deductibles trying to do, and how well do they do it?
I think the idea behind insurance deductibles, including patient cost sharing more generally, so co-payments, co-insurance deductibles, is that there is high value care and low value care. And when patients are fully insured and they have no out-of-pocket spending, they might overuse some care. And so the intuition was, well, if we introduce something called skin in the game, if we don't uninsure the patients because that's too much skin in the game.
Yeah.
What we do is we say, hey, Harold, you need this medicine. We're not 100% sure you need it, but if you really do need it, you'd be willing to spend a little bit of money out of pocket. And so by making you spend a little bit of money, we separate the people who need the medicine from the people who don't need the medicine. That was the intuition, right?
And that makes a lot of sense. If we were buying sweaters or something like that, this would make a ton of sense. Like, I know how much I enjoy sweaters, and if you give me some skin in the game about that, presumably I could make some useful decisions with that. So what are some issues that come up with this?
I think it's an empirical question, right? How well are people, human beings, able to respond to patient cost sharing, right? Human beings are not like the economists who designed these programs. The economists had good intentions, but they're used to thinking about prices, and they're used to thinking about, is this $10 copay worth this medicine, right? But a typical patient might say, you know what, this is a $10 copay. This is a really annoying problem for me to figure out. I'm just going to skip the medicine. Because it's not because I think the medicine won't help me. I just think that skipping it for a couple of weeks, that's not going to hurt me, right? And so in practice, a deductible doesn't really induce the kind of behavior that we hoped that it would induce. It doesn't induce the kind of super rational economic decision making that we thought it would induce.
Yeah, one of the interesting things, your paper involved a very educated workforce. People are some sort of a high-tech firm that was kind of very highly paid high-tech workers. Although the firm is anonymous, it's clearly a workforce that has much higher income and education than the typical people, and yet people really struggled to respond sometimes to fairly obvious economic incentives that the deductibles created for them, but that it kind of required that people really take the time to and prioritize. I'm going to respond to this economic incentive, understand it, and I'm a computer scientist with diabetes, and I've got a deductible. Let me think about it's January. Let me think about what I should be doing, how I should be responding to this thing, knowing that I'm going to hit some out of pocket limits and stuff, just given my personal health. That's not what people do. And I should say, by economists as patients do not act the way economists as policy planners hope that we would behave. And I mean, I remember my wife actually had a very serious medical scare this year, and and I can't say that I ever asked the price of anything or looked into, did any comparison shopping or thought about how I could economically optimize what we're doing. It's like, no, I want to get this MRI and figure out, is this thing a serious problem? And, it's a very psychologically freighted thing, when you're dealing with a health challenge, that we don't really want to do a whole OJ trial to optimize our decision-making very often in those kinds of situations.
That's right. So let me just add a little bit of color to what you said. When we started this project, and as your students know, this was done with Zarek Goldberg at Chicago, Ben Handel and John Colset at Berkeley, and we were
Stars,
working
by the way, really serious stars in the field. You go ahead. I'm
Oh
sorry.
yeah, absolutely. All three of them completely. I mean, they're just wonderful people whose papers you should always look at when they come out.
Mhm.
I remember when we started this project, we were worried that we might find that this super tech savvy, relatively young and wealthy workforce responds to cost sharing exactly the way economists want them to respond. And then we would have this paper saying, look, people respond super rationally, and other people would take our result and then apply it to everyone else, screw up healthcare for everyone else because of the extrapolation
Gotcha.
from this tiny slice of the population that gets it right. So we were actually worried that, in some sense, we'd have this very boring result that wealthy, rational computer scientist types know how to respond to these very nonlinear price schedules. And so we were really surprised when we found that this tech savvy, young, wealthy workforce makes large mistakes, doesn't look anything like the rational patient. So, it's another way of saying, had we done our study in another population, maybe a far more disadvantaged population, we would be finding even worse results.
Now, by the way, it is possible that a less economically advantaged population may pay more attention to some aspects of this because they have more reason to care about, okay, I'm wasting some money in my healthcare if I'm making 250 grand a year as a computer scientist, it's okay. By the way, I should tell you that I'm a liberal Democrat, which makes me the House conservative at my school. And so I also want to, many of our students come in with a very fundamental suspicion of economics. And I also, so maybe I should balance the discussion that we just had, which I think was terrific, with what are some insights from economics that you think are just really incredibly important for us all to understand when we think about a really critical policy like healthcare, where people really do respond to incentives, or markets really do work in a certain way that economics predicts that many of us from outside the field might kind of be resistant to, but that the data says, hey, you got to pay attention to that.
The reason I love being an economist is because of our discipline's emphasis on measurement. So you can write down whatever theory you want to write down. People are rational, people are irrational. You can write down a model where they're rational until lunchtime and then they're irrational after lunch. You could write all of those models down.
Oh, we should meet afterwards and make a paper. Yeah.
Right. And you could write down models where people are irrational when it comes to healthcare, but super rational when it comes to shopping on Amazon. The question for public policy is, what is the evidence? And so what I love about being an economist is this kind of quiet cadence of measuring, how well does this theory do at actually describing the behavior? So that's what makes me an economist. And one of the things I've learned is that sometimes we're very wrong and sometimes we're more right than anybody else, wants to give us credit for, because we're not, the most popular people. But it's an empirical question. Right.
Yeah,
so
I think that's actually
measuring things. As long as we're measuring things, I think we're economists, right?
By the way, I think compared to 25 years ago, there's been a real improvement. I think 25 years ago, the cool kids in economics sometimes were kind of lost in theory, and now the cool kids are like, I'm out in West Africa trying to improve sanitation by doing a randomized trial and evaluating people like Michael Kramer and who are really not only measurement but also experimental methods and one of the great things about the experimental methods is it's actually forced people to go out into the field. So when I was trained, I sort of spent a huge amount of time in the basement of the Harvard Science Center running computer tapes. Right. And I think now a lot of young economists like, I'm actually in a real world setting. I'm in Cook County Jail doing an intervention or evaluating an intervention, and talking to people who are incarcerated people in the Cook County Jail, and I think the profession has actually improved, I think, in that way over time. Although it's problematic that economics is so dominant, but that's a whole other discussion. I mean, I do think.
Yeah, I think if you look at the big problems that any society is grappling with, right? I would put, how do you get healthcare to everybody at the very top of that list? How do you provide great education, particularly to children, at the top of the list? How do you reform the criminal justice system, which is just rife with a whole bunch of, biases? I think one of the great things that we as a profession have done is recognize that our simple theory models may have a kernel of truth to them, but that's not good enough for public policy. So you really have to measure what works and what doesn't when it comes to say, how biased are judges, right? Like what can we learn about the implicit biases of judges? What can we learn about the implicit biases of doctors? We can't talk to them and say, are you implicitly biased or not, right? We have to find a way to measure this in the real world. And I think, to your point, we have certainly gotten out of the basement of the Littauer Center from 25 years ago and found ourselves in those jails and in those hospitals doing that kind of measurement.
Yeah, I think that's, by the way, there's some really, what we're doing in this course, we're doing basic, intro, micro. But I think for students that are following up a course in econometrics, where you look at things like, we find a situation where juvenile defendants are kind of randomly assigned to judges. And then we sort of find some of the judges are more lenient than others. Okay, what happens to those kids 5 years later? Sort of the Joe Doyle's work, where, it turns out the more lenient judges, the kids are having better outcomes over time. And that's a really important finding. And the fact that it's kind of done in the dry methodology of economics, in some ways makes it more credible.
I agree, because it's more neutral. I mean, my old friend Bruce Sacerdo did a number of incredibly influential studies on peer effects, where he worked off the random assignments of roommates. And he said, if you were assigned a roommate very different than you based on income or based on race, do you benefit from that, that roommate's social connections? And the answer is yes. Do you hang out with people who are different than you for life? The answer is yes. Well, we didn't know any of those things, right? And even the people who say, well, of course, that's all obvious. No, it's not obvious, because none of them could have quantified the magnitude to which my friends are affected by my roommate. Simply saying, well, they're affected is not saying, are they affected 50%? Are they affected 90%? How much does it change? So I think this measurement revolution in economics has certainly been an extremely exciting force.
But I think the last point you just made is also really critical, that it's pretty obvious if you increase, for example, unemployment benefits, there will be people who will, at the margin, will not take a crappy job and they will stay on unemployment. If you said to me, you're getting paid $1,000 a month unemployment benefit and a job just opened at McDonald's, and you 59-year-old Harold Pollack dude would have to stand, over the French fryer for 8 hours a day and get $200 more a month than you would get, staying on public benefit. That would be an incentive that would affect me. How many people that affects and in what way is an empirical question. And very often, one of the ways that we see sloppy public discourse is somebody says, hey, it's just basic economics 101, supply and demand. If you encourage people not to work, they won't work. Well, yeah, but are we talking about it's having a 5% effect or a 50% effect? That matters a lot, and
you've hit on one of my core peeves about the public discourse, which is people will say very knowledgeably something like, oh, why is healthcare broken? Well, it's all about the incentives. The incentives aren't there. Patients, going back to your point about low value care, patients have all the incentives to consume all the healthcare that they want, which is why you need these deductibles and co-payments. And in some subsequent work that we did during the COVID pandemic, we realized when people cut back on their medicines, they don't just go to the hospital, they die, because they don't know often which medicine to cut back on. So this is the sequel to the What Does a Deductible Do paper.
Yeah.
And so I think one of the problems with the public discourse in America in health policy is that increasingly that discourse has become the discourse of accounting. How do we save money in healthcare? Well, that was never the goal of healthcare.
Yeah, if we wanted to save money, we could shoot the patients. That would save a lot of money.
100%. The goal was never to save money. So like bringing in this, how do we save money is just a bizarre criteria. The goal is how do you help the poor and the sick with healthcare? That's the goal of healthcare. Very often that means spending more,
Yeah.
expanding coverage, making coverage more generous, reducing deductibles.
Well, I do think though, although I would add one hard-headed aspect, which is like Harold uses Flomax, and maybe Harold should use generic Flomax, and having some financial incentive that says, use a generic medication when that's available, that's biosimilar. You know, it's appropriate. You know, I'm a professor at the University of Chicago, some economic incentives for me to avoid certain obvious low value things.
I think that using
makes sense.
Co-insurance, co-payments to discourage the use of a brand when a generic is present, or medical therapy A when equivalent medical therapy B doesn't even have to be a generic, it's just equivalent, known to be equivalent. That seems perfectly correct.
Yeah.
Right. But we live in a world where most of our therapies, most of our technologies are actually quite differentiated. Right? Just because you have two drugs for multiple sclerosis doesn't mean that they're equivalent for you. One may be better than the other. And so in that world, the blunt copayment is a very cruel thing to use, because what we're also saying is we're saying to the patient who has MS, oh, you have MS, congratulations, now you get hit with the copay. You know, so it seems like it's an unethical kind of thing to do. Or you've got a patient with a rare orphan disease and you say, you know, oh my gosh, you have this rare orphan disease.
Yeah.
You have health insurance coverage, but you have a 20% co-insurance for this $300,000 drug. You know,
also,
so
the other thing that, just one moment, I'm just going to tell my next meeting that I'm a little bit delayed, that you're more important than they are. The other thing is that you're telling people at a moment that is very difficult for them. By the way, we also want you to do an OJ trial around figuring out what's the cheapest drug or whatever. And one of the things that we can do, we could do a better job for people is to say, you know, we want you to use some cheaper drugs here. We're going to help you figure out how to do that. And we're not going to just put an economic incentive on you and say, you figure it out, you know, so that you're sort of comparison shopping from a gurney, you know.
But Howard, let me add one wrinkle to this whole mess. You know, I no longer think that economic incentives by themselves are sufficient to remove low value care, but I also don't think it's information. I mean, in some new work that you've not seen that we'll put out very soon, but it'll be in the public domain. You know, if you look at the healthcare decisions of doctors and nurses, I mean, this would be the most educated patient in a sense. This would be the paragon of an expert patient. This, you know, this is a patient with an MD. It does not look like their healthcare decisions would align with what we would call, you know, consuming high value care. I think healthcare is just fundamentally hard. It's not like I'm not saying the doctors and nurses don't know it. I think they know it better than anyone else. And despite that, they don't always know when do they go to the emergency room. They'll end up going to the emergency room about as much as you and I do.
Yeah.
Right.
By the way,
forget taking their meds about as often as you and I do. The being human part is much bigger than the being richer or being more informed part.
That's so interesting. But the obsession with reducing inappropriate emergency department use is something we could have another conversation about. But I remember I've been involved in many Democratic campaigns, and one of our most congenial talking points was always, if we did universal coverage, people would rely on the emergency room less. And it was, by the way, never an evidence-based claim ever. And one of the things that I learned from that, by the way, was one is tempted to depart from integrity with a congenial political talking point. And not only is that the wrong thing to do, then at some point you will be called out on it, and your opponents will correctly say, you know, you were pushing something that was not well-founded. And And we know one thing we do know that actually economics does speak to is demand curves do slope down. And if you subsidize, if you say to someone you're well insured for emergency room care, people will probably go to the emergency room a little more. It's not clear that's a bad thing at all, but we should just be straightforward that there are some aspects of economics that are pretty straightforward. I remember when my wife had a heart problem and we were debating, should we take her to the emergency department or not? And I was like, well, it's probably indigestion and it's going to cost us like $700. Let's not go, which by the way turned out to be a catastrophic mistake. She had a heart infection. Although fortunately she was fine. But, I was thinking about the money, and if you said to me it's free, I would have gone more assiduously. And in that case, would have been good. But, well, let me, I've kept you over. I hope that at some point we can meet IRL, and thank you for the work that you do, and for being a fun e-friend on Twitter and in other locales. And congratulations on all the important work that you do. It's really making the world a better place.
Errol, it is absolutely wonderful to see you. You were one of the first health economists that I met when I was setting out on this, and you encouraged me to do it. So here I am. I'm still doing it, and it's just great to have this brief conversation. And yes, you're right. Let's meet in person next time.
Well, you have far surpassed me in those domains, which only proves that I'm more right than I thought I was when we talked the first time. Which is of course the key economic insight at any health economics seminar.
Bye, Harold.
Bye. When we stop the